Hello.
Assalamu alaikum.
Assalamu alaikum.
Assalamu alaikum. Can you hear me over there? Well, says Pakistan Live. Can you hear me?
So, can you introduce the case? And
Hello.
Bilal, we
Well,
can hear
says
you. Can you?
Pakistan Live. Can you hear me? Assalamu alaikum.
Walaikum salam.
Well, says Assalamu alaikum. Well, says Pakistan Live. Can you hear me?
Hello, Bilal, we can hear you.
We can hear you.
Assalamu alaikum. Can you hear me?
Yes.
Yes, we can.
Well, says Pakistan Live. Can you hear me?
Yes, we can hear you.
Thank you. Welcome to Punjab Institute of Cardiology, our cath lab. Over here, we are doing a couple of cases that you will enjoy sharing, with you, and I hope this is going to be a great learning experience. So, with the name of Allah Subhanahu wa Taala, we start our proceeding. A'udhu billahi minash shaitanir rajeem. Bismillahir rahmanir rahim. Qul huwallahu ahad, Allahu samad, lam yalid wa lam yulad wa lam yakul lahu kufuwan ahad. Our first case will be presented over here. May I have the slides on that side, please? Focus it on. Okay, so, as you can see, read over here, it's a 72-year-old gentleman. उस पे चले जाओ ना, slide show पे. 72-year-old gentleman. The diagnostic. In fact, I would like you to read this all thing out so that it's very simple over there. No big deal as far as the history has been. ECG, please show the ECG. EF is about 40%. That's your ECG, as you can see. Next, please. An echocardiogram. Focus on it, please. An anteroseptal hypokinesia with an EF of 60. Yeah. Deep TV. I'll give my mic to Dr. Rana over here, and he'll discuss the case with you as we proceed on.
So, as you can see, that there is a trifurcating or probably tetrafurcating left main, and there is a tight ostial stenosis of the left anterior descending artery, as you can see in this view.
Please,
there is a distal stenosis of the left main as well, and the question is which strategy the operator would choose in this case, and it's open to the panel for discussion right now, which strategy you will go for. So over to Dr. Bilal.
Can you show us more views of the angiogram?
What do you want to see kindly?
Please show us different views of the coronary angiogram, which you did before the procedure.
So as you can see over here, this is the spider view. No. Now you want to see do you want to see the live cases?
Can you put it on?
Yeah, we'll show you in a minute or so. At the moment, they are just proceeding on. And this is the main question over here, that how would you like to manage this trifurcating left main?
Bilal, can you show us Bilal, can you show us the images on the main screen? We are not seeing it right now. Can you show us on the big screen?
Yes, we will show you images on the big screen. At the moment, they are progressing on with the case. So, with me over here is Professor Cheng, Dr. Muzaffar, and Dr. Sadia, who are Professor Muzaffar and Dr. Sadia, who are into this case. So, Professor Cheng, would you allow us to show the cases now? First case, first slide, first view, please. First view.
Yeah, this is better now. We can see that. But we can't hear Dr. Chen. He doesn't have a mic.
Yeah, can you hear me clearly?
Can you keep mic a little bit away because we're getting a lot of echo.
Yeah, can you see angiography?
Yes, we can see it now.
Yeah, this is I think this is epicaudal. So we use the same French guiding test transfemoral approach. So epicaudal is a typical distal left main trifurcation lesions. Also, downstream circumflex, there is also very tight lesion. But from epicaudal, you can see the proximal circumflex lesion length greater than 10 millimeters. but the diameter stenosis is less than 70%. Next view. Yeah, this is the IO caudal. I think the same findings from the epicaudal. Next. But from both views, you can see a very diffuse lesion. This is the IO cranial. So San French guarding cancer, distal AD looks like 2.5. And there is a very diffuse lesion from the crossing from middle pouch to the ostial LAD. Next. Yeah, this is one more shallow IO and the cranial to show the distribution of lesion in LAD. Next. Yeah, I think this is a fun shot of spider view. So you can see typical trifurcation involving AD, Sunflash, and Ramos. So what we should be kept in mind is that this is the same French guiding. So this Sunflash looks like 2.75. 304 proximal AD and 304 Ramos. So the left man should be greater than 4.5 millimeters in diameter. So these are angiography we took today. So next I'd like to show next we pre-dilate. We use a 3-wire, one in Sunflash, another 2 in the LAD and in Ramos. Next. Yeah, so from this is the last shot of
Dr. Chen, maybe we can get some...
successfully put 3 wires in the vessel.
Dr. Chen, can you stop? Can we stop and maybe get some opinions from the panelists? Bilal, keep your mic a little bit further away and speak slowly because there's a lot of echo and we are unable to understand when it's close to your mouth. So let's see, let me get some opinion from our panelists who are online. Maybe Dr. Cheem, are you there? If you can tell us how would you do it or what will be your strategy?
Hi, I'm here. So, hi, Xiaoliang, this is Huaiqing here. So, just looking at the anatomy here, I'm not so sure whether the ramus is really that tight, at least angiographically. So, I for sure think that the distal left main and LAD are significant. I'm not so sure about how significant the ramus is or the ostial circumflex. So, some kind of imaging will be very helpful here, or even physiologic assessment. So my take here is that I'm going to take a provisional stand approach here first. Deal with the LAD and the left main, and then coming back again to reassess the circuit RC and the ramus.
Okay, Bilal?
To hear your question, are you in Singapore or in Pakistan?
In Singapore.
Okay, good.
Bilal, do you,
Where are you from, Jafri, over there?
can we get, I was going to ask other...
So now what we have done so far is that now we have got our, we have done the balloon dilatations and we have the IVUS images with us. So we'll now share the IVUS images with you.
Yeah, this is a 3O NC balloon for pre-dilation. Just a pre-dilate proximal AD to left main. So next, Dr. Anjung, can you show the IVUS finding? So we start from distal AD to left main. Can you see IVUS image? Hello?
Can you show the IVUS images now?
Yeah, we can see that. We can see the IVUS images.
You can see the IVUS?
Go ahead.
Okay, good morning. This is Dr. Anjum. And this was the first, this is the volcano catheter. And the first pull back is from the mid LAD and back to the left vein. And, you first see the running cine and then we'll stop around the left main ostium and distal left main and the ostial LAD as well.
12 or 15? 15, you sure? Let me double check. The balloon. Okay.
So this one is the osteoproximal LAD. You can see there is severe stenosis. There is huge plaque burden over here. And if you want,
3O by 23.
you can see the catheter is almost accumulating the lumen, and there is a huge plaque burden over here. So we'll do the measurements. This is the proximal, osteoproximal LAD over here. And you can see over here the plaque burden is 72.2%. And the area, the mean diameter over here is 2.3. This is for the proximal LAD. And then we try to stop at the distal left main. Over here you can see practically this is the ostial LAD, and when we pull back, this is the first branch joining at the 3 o'clock position, you can see, and this one is the ramus. And then the next one is the left circumflex joining at 1 to 2 o'clock, and these two bright shadow, these wires, you can see at the ostium of the circ, and in the distal left main, the other two wires you can see. And now just proximal to that, this is the left main distal. And you can see there is huge plaque burden starting from the 11, 12 o'clock, going right up to the 7 o'clock. And this is the distal left main. This is the body of the left main, and this is the proximal left main, which is relatively plaque-free. And in order to estimate the size of the left main over here and the plaque burden in this area as well, we'll do some drawing.
Okay, I think let's get some more comments from the panelists, how they would proceed. Bilal, can you hear me? So how would you approach in this case after looking at the IVUS and the images? Either you would go provisional, wiring, and what would be your strategy?
Yeah, thank you. I think that the IVUS clearly shows significant plaque burden in the LAD. As Dr. Khan mentioned earlier, we don't quite know the plaque burden in the ramus circumflex. My approach towards these really complex stratification is to try and keep it as simple as possible. I think the more we make it complicated in terms of bifurcation stenting strategies and metal overlap in these areas, the more we are likely to create a nidus for restenosis or thrombosis later, because we don't know the patient's compliance. We have to make sure everything is expanded. Personally, I would wire everything. I would treat from the left main to the LAD. I would reevaluate the ostia of the ramus and circumflex. It's either imaging or physiology. If this is not hemodynamic significant, if the lesion luminal area is large enough, leave it alone. If it is somewhat compromised, maybe do a cutting balloon through the stent strut or something to keep that open. But I would try to minimize the need for complex trifurcation stenting over here in an area like this.
Dr. Rosalie, your comments?
Yeah, I think, thanks, Bashir. Nothing more to add, and I would tend to agree about the comments that make it simple and, provisional stenting first. You don't want to be adding too much of stent in that area, even if you just stent the circumflex. If there's need for it, then the flow in the ramus may actually be affected. And I think worse still if you think about putting in 3 stents. So make it as simple as possible.
Okay, Dr. Chen, go ahead and tell us what's your plan, what are you going to do?
Okay, Professor Chen, we have to show one more image. Professor Bashir Nadim.
Go ahead.
We want to show one more image. The second run of the IVUS was from left circumflex to the left main. Okay. And this is the area of the ostial left circumflex. And you can see, basically, this is relatively plaque-free. So the plaque burden over here is only 25%. And the ostium of the left circumflex looks wide open over here. So now I will, over to Professor Bilal and the panelists.
Perfect, thank you. So I think you wanted Professor Cheng's opinion.
Oh, thank you. Bashir, can you hear me clearly?
I can't hear. Can you speak loud a little bit or close mic?
Raz, okay.
Yeah, it's okay now.
Okay. Yeah, after predilation for LAD, which I think Dr. Anjong has shown where I was imaging for you. Immediate after predilation for LAD, angiographically there is heaviness at the very proximity. So I do believe there was unstable plaque at the proximity. It doesn't matter. So according to angiography and I was finding, my strategy is that I will use a one-stent technique, provisional strategy to cover the LAD lesion protruded into the left main And then we will check the blood flow in the sunflares as well in the ramus. Angiographically, also in sunflares, the diameter stenosis is around 50%. So according to our definition criteria, even if it's a trifocal lesion, it could be classified by simple bifocal lesion. This is my decision. So I will go through using 135 by 35 by 23 DES. This is the science, I think.
Yeah, this is a science expedition.
Okay.
Okay. Yes, yes.
So what was the size of left main on IVUS?
Oh my God.
What was the size of left main on IVUS?
Left main size on IVUS. Rana?
Left main IVUS.
Left main size on IVUS.
Reference vessel diameter of left main is about 4.5.
Okay. So the reason I was asking is what kind of stent you would be using if you have to really, there's a mismatch in LED and left main, obviously you need a much bigger balloon in the left main. So Dr. Mansoor, do you agree with this strategy of going with a single stent and then see how it behaves?
Yeah,
On. Usko on kar le, mic aapka off ho gaya.
it's a perfect way to go, really.
Okay.
Keep it single stent, and if needed, then provisionally you can do anything further.
Dr. Ijaz?
6,
9,
9,
10.
10.
This one says down. Down. Okay. So I think the distal segment of stent was not fully suspended. Can you see angiography? Basha, can you see angiography?
Can you see the angiogram?
So did you keep the stent in the mid left main or did you come to the ostium? I think it looks like you just covered went to the mid left main.
Yeah, just to cover the POC area.
Yeah, they have covered up from the LED up to the mid left main.
Mid left main, okay. I guess you want to make sure that you have
As you can
enough
see, the
left
circumflex,
stent in the
the
left
intermediate
main.
wire is out.
You want to make sure you have enough stent in the left main to be able to post dilate it with a bigger balloon.
Good. So far, so good.
Yes, definitely. I will use, but you know, right now, after studying
4.5.
before flat and the ramus, but my next requirement is very short, 4.0 non-compliant balloon. 4.0. You have 4.0.
Yes.
4.0 very short, NC balloon. So, Basha, I think this angiographically, even if it looks like very complicated, but in fact, this is a simple bifocal lesion. One more shot.
Yes.
Okay. Go ahead. Good.
Shao Liang, do you think we need to post-dilate the LED as well?
Yeah, absolutely. So I will start to post-dilate the proximal stent. So I will use 4.0, and then I will use another 3.5 to post-dilate LED stent. But are you happy about the provisional stent technique?
Okay, so Fahim,
Thank you.
Fahim, are you there?
Yes, we are here.
Yeah, Fahim, no, so let's see after post dilatation, are you going to, let's see if it looks like this, there's not significant compromise to the ramus or circ. There is always a debate, should you go back into the circ and try to open up the struts or leave it alone with a smaller balloon? What will be your strategy?
No, I will, after post-dilation, if still TB flow is, can you hear me? I changed my microphone. Basha?
Bashir Saab, can you hear him?
Yeah, we can hear.
Okay. So after the post-dilation, if the TB flow in both sunflares and also in ramus still grade 3 and no any sign of dissection or thrombus formation, I will just remove the wire. I don't want to touch the sunflares and the ramus after the post-line. Test for me.
Yes.
Small test. Okay, infection.
So
Just A.
let's play devil's advocate. If let's see there was a compromise to circ and
Yeah.
ramus
Yeah.
after stenting, Fahim, what would you be doing? Like what kind of strategy if you had to end up stenting? Would you be using a drug-coated balloon or put another stents in, DK crush, triple crush? What are you going to do? It seems like they are lucky here. There's not much compromise to the ramus or the circ. But let's see if there was one, what would you do?
Yeah, actually, basically, before the procedure, we have just cost much more with Bilal and John Angel. So, because this is just left main trifocal lesion, we have multiple choice. First option will be up from the two-step technique. Personally, I like to use the DK parts. Secondly, we can work. We can start to work from provisional. Regarding provisional standing technique of the stent, if the ramus and the surface are pinched very much, so you can use the NC balloon, drug pulling balloon, or even second stent. It depends on the scenario after understanding IAD left main. But for trifocal lesion, so far there are only 3 papers reported the long-term clinical follow-up. One is by Dr. Imad Shiban from Italy, who reported 76 left main trifocal lesion. So if we use 2-step technique for trifocal lesion, by 1 year follow-up, almost 7% of patients will die. Another serious study from our side, we also compared 1 stent and 2 stent for trifocal lesion. By 2 years, so the cardiac death will be 12%. So that means the most stent you deployed for left main trifurcation, the higher rate of cardiac death. So this is why finally we decided to use the provisional sliding technique. Also, from the angiography, you can see at least the 2 stent struts protruded into the circumflex. This is a good sign. Can you see angiography clearly? Very, very clearly. So at least the 2 struts protruding into the circumflex. So this is the 4O non-compliant balloon for post-dilation for part. Just for proximal ID, left main stent. I need another 3.5 ND balloon to post-dilate the distal ID stent. After that, I think we will recheck the IOS for ID stent, that's all. So now we have finished the post-dilation for left main stent.
Okay, Dr. Chen, you can continue working. I'll get some opinion from the panelists over here. You can continue working on post-dilatation. Dr. Low, would you be doing the same strategy as Dr. Chen did it, or you'll do anything different?
I'm very similar. I don't routinely treat those eye branches, particularly after intracoronary imaging. So I think I was happy that imaging is done, and I think when you have to stent the left main LAD, you have to leave enough room for a good post-dilatation. And I think that if the side branches are non-compromised, I would not routinely open the stent struts. So I'm very similar to Professor Chen.
So if there was a compromise to the ramus or the circ ostium, how would you do that?
I think if it's a nasty dissection, I'll be forced to stent it, and a tap stenting or T stenting would be necessary. But if it's a minor thing, I would try to do drug-eluting balloon of the ostia and see how that goes. And I suspect, because of the plaque burden being very low, the ostium of the circumflex, drug-eluting balloon may work very well. But that's after a successful ballooning before I would treat it with a drug-eluting balloon. And so if it's a nasty dissection, you're forced to stent it. But I probably would stent depending on which vessel. I tend not to have a trifurcation stent, generally speaking.
Well, just a quick question that, when you've got a stent across the left main to LAD and you're saying that you want to take a drug-eluting balloon into the circumflex, are you comfortable to take the depth through the struts? Or you are really going to put your wire in, yank open the struts over there, make sure that your balloon as you go through does not drop against the struts and cause loss of the medicine or piling up of the medicine? So what is your take as far as that is concerned? Because there's always a debate about going a depth through the struts.
Yeah, I think Fahim or Dr. Rosalie can answer those. They have a lot of experience in using drug-coated balloons. Fahim?
Well, I'm sure Sydney would also be able to answer that. But Yes, I tend to open the stand struts up because you want to ensure that you will be able to pass the balloon across. Secondly, I'm not worried about the drug being rubbed against the stand struts because the majority of drug is within the folds, so that shouldn't be a problem.
Mirvat,
You see, the
would you do
point-
anything different?
You have the old stents which were tri-connected and now the newer one which are bi-connected. So if you have a tri-connected stent, they normally don't open up to about 2 millimeters that you barely need to go through it. So what is your take on this?
Sorry, I didn't understand. What you, can you repeat the question?
I'll repeat the question.
Keep
that
your mic a little bit
you have
further away.
those
There's a lot of
stents
echo.
which are tri-connected, and then you have the bi-connected stents. Now, you need to have at least 2 millimeters space to get your stents in. You need at least 2 millimeters space to go through. So if you don't have those 2 millimeters space, especially with the tri-connected old stents, whatever.
No, we lost your voice. I'm sorry. We lost your voice at the end and there was too much echo. We can't hear you anymore.
Can you hear me now?
Yeah, we can hear you now.
Okay, my question is that you have those old stents which are tri-connected, and then these are newer stents which are bi-connected. So when you go through a tri-connected stent and you try to dilate out that thing, these are the struts. The struts normally do not open up to 2 millimeters, which is a basic requirement to take your depth through. So that is my point, that will you consider going through a tri-connected stent or never through a tri-connected stent?
Yes.
Okay.
That's what I was basically.
Dr. Rosalie, did you understand the question?
Sir, what was the size of the stent which has been deployed in left main to LED?
Okay. So I was
3.5. And which stent is this?
I was really good.
Okay.
To identify if there is a digital
Okay,
dissection.
Dr. Alasnang,
So you can see
can
now,
you give your comment or how would you have done it differently or same way or anything else you would like to add?
From Ramos. And
Mirvat?
subsequently, I posted that LEDs using 3.5 non-compliant balloon. So this is last shot to show very good expansion of stem and a very good flow in some flats and Ramos. So I think this will be the last step to recheck the IVOS. I will start from the stent distal edge to see if there is any sign of dissection because it's a 3.5 stent.
So you post-dilated the LED and left main?
Pardon me?
Have you post-dilated the LED and left main both?
Yes, I have done.
What size balloons?
The proximal part of the stent was post-dilated with the 4.0 and the distal was post-dilated with the 3.5.
Record.
Okay. So can you show us the IVUS on the screen?
Proximality looks undersized and expansion.
Can we see the IVUS? We are not seeing the IVUS.
Yeah. Okay, stop.
Okay.
Okay, now we can see the IVUS.
Yes, maybe not oversized.
Yes, you're right.
Still undersized, you see?
Yes.
Yeah.
Yes. No edge dissection. Perfectly placed, you know. Yes.
Can you see IVUS image?
Yes.
I think the Dr. Anjong will introduce IVUS fighting for you.
Okay.
So give me.
Okay. ये माइक मेरा है एक क्वेश्चन
So give me 5.
Mirvat, can you hear us?
So, sorry, so can you see the IVUS image?
So after looking at the IVUS, would you do something else or leave it here?
Okay, this is the IVUS run done from the LED to left main, and now here this is the stents, well expanded, well opposed. We will also calculate the MLA, and over here we have stopped because at 2 to 3 o'clock you see the ramus and the left circumflex, they are joining. And now this is the proximal end of the stent strut, landing just in the distal left main at the junction of the distal left main and the ostial LED. And you can see the left main, which is not stented, that is plaque free, and there is no dissection or something. This one is all the left main. This is the ostium of the left main. Here you can see. I will again, go to the osteoproximal LAD and do the MLA over here. Okay.
So, Dr. Anjong, can you measure how much is the minimal stent area?
Okay.
So
this is the osteal
let me ask the
osteal
panelists,
LAD.
are they happy with the stent on the IVUS or would they like to do anything else? Dr. Alisnang, you are going to say something. Are you okay with the stent or do you want to do it with a bigger balloon or what is your opinion?
What I see is in the LAD, the distal LAD, it's well expanded in post, but I think as you get closer into the LAD, there are segments that need more post-dilatation, I believe. But we do see that our branches are intact, so, the ramus and stuff, so that's good.
So what do you think about left main stent expansion? Is that adequate or would you use a bigger balloon in that?
Yeah, I would do some pot in the left main, and I think that's something we
They did with
consider
4.0.
when we decide on length of stent and where we land it, that we need to have adequate
They use 4.0 balloon in the left main. Would you go to 4.5 or leave it at 4?
How many is the minimal stent area?
Okay, sorry. On IVUS, this is the distal LAD near the distal stent outlet, and the MLA over here is 5.2 millimeter square, as you can see.
So it's already big enough, right?
And at the osteoproximal LAD, which is this area, so we'll calculate it over here as well.
How much?
And at the osteoproximal LAD, the area is 7.3 millimeter square, as you can see.
7.3. So it has already big enough.
Yes.
But according to the IVUS, Batia, can you hear me? My friend.
So
we hear you.
We had a discussion, Dr. Chan, I'm going to just ask a couple of panelists about that. We had a discussion yesterday that after the stenting, MLA versus malapposition versus under expansion, which one is going to be more important or which is going to be kind of a risk for stent thrombosis or restenosis in the future? A lot of people were of the view that if your MLA is like more than 4.5 or 5 in the LAD, and even if there is some malapposition or under expansion, it should be okay. Dr. Chim, if I ask you, what do you think? Which one is more important?
Just looking at the IVUS,
already big enough.
I'm actually quite amazed that actually there are very little stent struts in the distal left main. And I think right at the ostium of the LAD, we can actually take that 4.0 balloon and just take it up to a nominal pressure. But I think we still need to get the distal left main properly expanded. So there's actually very little stent struts in the distal left main based on this IVUS. So I would take the 4.0 balloon and go down again. I certainly want the stent to be expanded and well approached here because this distal left main is not normal. So they are plugged behind the stent strut. So I want to make sure that it's well approached here.
Yeah, record.
So what about if the LAD MLA is like more than 5? That should be okay, or you would still go with a bigger balloon? If it looks like under expanded or malapposed on IVUS.
No, I think we can take the 4.0 for the ostium LAD and then same balloon again, higher pressure.
So, Professor,
I have post-dilate left main stent using 4.0 non-compliant balloon. After first round of IVUS, so Dr. Anjong calculated the minimal stent area in LAD was 5.0 millimeter square and 7.2 millimeter square for ostial left main stent. But even the minimal stent area is big enough. But from the IVUS, I do believe the expansion index. It means the symmetry index, the actual diameter is not big enough. So after that, back. No. Previous. Yeah. So no, previous.
Minus.
Yeah, previous.
Minus.
Yeah.
Minus.
No.
Minus.
No. I think I did not recall. Okay, you can see this is a 3.5 NC balloon to further post-dilate AD scan and by 20 atmosphere, and also sequential until to the left main scan by 20. So I think Dr. Anjong will introduce the final IVUS measurement to you. Go ahead, Dr. Anjong.
Okay, so for the panel, I will revise that after the first IVUS run, the distal LED is again post-dilated with 3.5 at 20 ATM, and the osteoproximal LED is again post-dilated with a foro balloon at 18 to 20 ATM. And this is the second IVUS run, where the frame is over here. This is showing at the osteoproximal LED, and now over here on the bottom of the screen, you can see the MLA over here is 10.2 millimeters square. This is the osteoproximal LED. So the distal LED also looked a little bit underexpanded on the previous IVUS run.
Oh, wonderful.
And now we'll show the distal LED as well. This is the stents in the distal LED, as you can see. And we'll calculate the MLA over here as well. It looks well expanded.
So maybe you can show us the final images. I think the wire is out, so take the final angio. Did you take one?
So the distal LED is 7.3 millimeters square and on the IVUS. And can you show the final angio runs, please? Can you do a radial run, actually?
I think spider
Dr.
view will
Bashir,
be
can you
better.
hear me?
If you could show us a spider view.
Sir, my question to panelists is how many of you are in favor of doing final kissing balloon inflation? Because even you are going for the provisional stenting, so FKBI actually counts while you are doing the bifurcation stenting or trifurcation stenting.
Yeah, I think we asked earlier, Dr. Najib, would you do anything to the side branches, try to open the struts up or leave it like that?
To be honest, side branches or ramus or circumflex, I'm not concerned. I only has a little bit of concern that there is not enough stent in the distal left main. I think the stent just ends up just at the beginning of the LED to point to there, and if you look at the 4 millimeter balloon dilatation of with it, I think a lot of balloon was proximal to the stent. So that's the only concern. I'm not worried about the ramus or circumflex.
Okay, thank you. I think great case. Thank you very much. Thank you, lab. Excellent case. So we are going to move on. We are going to go ahead and do another debate, and then probably they have a case ready in the other lab, and we'll go there for a few minutes to look over there.
Thank you very much, sir.
Okay, thank you, Chief.
So now we are moving to second lab.
We'll go back to the debate now.
Intervention is waiting.
Okay, so the next debate is routine PCI for stable IHT obsolete. We have Fahim Jafri talking in favor of the motion and Nadim Rizvi against it. So Fahim, it's good to see you. Assalamu alaikum.
Assalamu alaikum, good to see you. Good to see you. Thank you for the invitation. Can you see my slides yet?
No, not yet. We can see you, but not the slides. Okay, now the slides are on. Yeah, they are on now.
Okay, great. So, assalamu alaikum, everybody. Thank you so much for the invitation. It's always a privilege. It's a privilege to be part of Pakistan Live. My job is to talk about routine PCI in stable ischemic heart disease and whether it's obsolete or not. So I don't have any conflicts of interest related to the discussion. Let me start with a disclaimer. And the disclaimer I have is that, I wear several hats, nuclear, CT, cardiology, but primarily I'm an interventional cardiologist. I do PCI for a living. And I would like to think that PCI saves lives in stable coronary artery disease in every patient with stable coronary artery disease. The fact is that data is data, and the rest of the arguments are just smoke. And so I'm going to hopefully try to convince you that for most patients with stable disease, medical therapy is a good initial choice. So I think starting off, I think the first thing is that I can end this debate right now because this is the wrong question. Is it obsolete for stable disease? No, it's not. Because the right question you have to ask is, are you talking about for symptoms or are you talking about for prognosis? And in a nutshell, for symptoms, the answer is no. And for prognosis, the answer is mostly yes, at least as an initial strategy, unless the patient has his or her own wishes. And so let's look at this a little bit more. For symptoms, it is always appropriate to do PCI when a patient has significant symptoms. And I draw your attention to the ischemia trial. We don't have time to go over the trial design, but everybody is now very well familiar with this 5,000 patient study. A lot of ischemia randomized to invasive versus conservative strategy. And in the ischemia trial, there was a durable benefit in angina reduction over a period of 36 months. But the reduction, the benefit was limited. It wasn't in everybody. It was limited to those with daily or weekly angina. In other words, people with a lot of angina. And that sort of is related to the fact that PCI will relieve the stenosis and improve angina. But the reason partly why it doesn't work in everybody is because of the fact that PCI also has a placebo effect. And if you look at the Orbiter trial published not too long ago, stable disease randomized to real PCI versus fake PCI, both groups had an increase in exercise time as well as an increase in angina scores, and it was not significant. Now, when you then talk about the more relevant question, which is prognosis, we all like to think that what we do improves lives or saves lives. The answer, in my view, is mostly it is obsolete, mostly yes, at least as an initial strategy, unless the patient has his or her own desires or wishes. And the reason for that is because in most patients with stable disease, when you do PCI, you do not alter prognosis. And I draw your attention to the Courage trial, stable disease randomized to PCI versus medical therapy, and over a 5-year period, no difference in death, MI, or hospitalization for ACS, and even over a 15-year period, no difference in mortality. I also draw your attention to the Fahim 2 trial, which is, we are interventionists, we like to talk about FFR, and over a 5-year period, no difference in death, and only a trend in reduction in MI, but actually the MI reduction was not significant. Of course, there are caveats to Courage. Patients were enrolled after angiography, and therefore, there was an exclusion of the more complex and more high-risk patients. And that is to a large extent true because in Courage, most patients had single or double vessel disease. Prox LAD was only a quarter of those patients. But then when you look at the ischemia trial, it was quite different. Patients were enrolled before angiography, not after, so there was no bias. Lot of ischemia. Most patients had LAD disease and the majority had multivessel disease. And when you look at the endpoint in the ischemia trial, over almost a 4-year period, no difference in death, MI, hospitalization, or cardiac arrest, no difference in death or MI, and certainly no difference in MI itself. There was a signal of reduction in spontaneous MI in the future, but that was balanced by an early procedural MI risk, these were big MIs. So overall, no difference. And when you look at subgroups, there was no benefit whether you had mild, moderate, or severe ischemia. It didn't matter whether you had 1 or 2 or 3 vessel disease. It didn't matter whether you had proximal LAD disease. And so then this begs the question that is ischemia no longer bad? And the answer is that's not true. Ischemia is still bad. It is related to MI, to outcomes. Extent of coronary disease is also related to bad outcomes. So both of these are bad. However, the point is that no matter how much ischemia you had, or no matter what the extent of coronary disease was, revascularization did not alter prognosis. And that's the important thing to sort of take home. Now, you will hear arguments about exclusions, and sure enough, the ischemia trial excluded ACS. So whatever we're talking about, it doesn't apply if you have ACS. And they also likely excluded the most severest patients with the most severe symptoms and the most extensive ischemia. But that is common sense. Somebody who walks 5 minutes and gets severe chest pain doesn't need to be treated medically. They need to go to the cath lab. So that is common sense. Most of those patients are more towards ACS than stable. Left main disease was excluded and low EF was excluded. So these patients are, whatever we talked about so far does not apply to these patients. However, the myth that PCI improves outcomes or prognosis in patients with low EF was sort of shattered by the revived BCIS trial that was BCIS trial that was published very recently. Admittedly, is not an ischemia population, but nonetheless, low EF, PCI versus medical therapy over 40 months, no benefit of revascularization or medical therapy. And so, with all this, then how do you put ischemia, courage, and all this together? And I'll just sort of go over how we approach patients with a bunch of chest pain in our practice. And so, if you have a bunch of patients with chest pain that you see, when you do a history, sure enough, some of them will have severe symptoms or accelerating symptoms. These don't need to go anywhere but the cath lab. You can put them on tablets, but they need to go to the cath lab. But for the rest of them, you can then consider an approach of stress testing. And when you stress test them, sure enough, many of them will have normal or mild ischemia, and a very small number of them will have a severely positive stress test. I'm talking about the guy or girl who walks on the treadmill for 2 minutes and the ST segments go up or the blood pressure tanks. And sure enough, these normal or mild ischemia can be treated medically, and the other ones need to go to the cath lab. But then for the rest of these, this large chunk of patients, before ischemia, they would all go to the cath lab. But now after ischemia, I think we have enough equipoise to think between medical therapy and invasive therapy. And you will then, sure enough, have a discussion about options with the patient. And sure enough, some patients will desire to go to the cath lab. They don't want anything else. And in the light of patients' wishes, it is appropriate to take them to the cath lab. But for the rest of them, you will then talk about ruling out low EF by an echo, which is easy, and then rule out left main disease, which we often do with the CT scan. And we do that because of these kind of patients. This is a patient in our practice who had inferior lateral ischemia, was sent for a CT, and then got lost because COVID hit Singapore, and then came back 6 months later with an ACS and had this critical left main disease. You don't want to miss them. And sure, when you find those with left main disease, they need to go to the cath lab. But the rest of them can be then treated medically initially. And when you treat them medically, certainly there will be some of them who will fail medical therapy and can go to the cath lab. But then for the rest of them, as you can see, majority of patients will do well with medical therapy, rather than an invasive approach, at least as the initial approach. And the guidelines are sort of leaning towards us. We have the 2018 European and the 2021 American guidelines, and both guidelines, of course, for the left main and low EF and refractory angina say, of course, PCI or revascularization. But the more recent American guidelines downgraded categories like single or double vessel disease with LAD, multivessel disease with low EF, or multivessel disease with mildly reduced EF. These were downgraded in the most recent American guidelines. And ischemic burden, which we've been talking about for years and years, all my career it's been ischemic burden. What do we do about it? It's important to address. In the most recent American guidelines, it's not even mentioned, so it's a less ischemia-centric approach now, focusing on medical therapy. And so if I was to conclude, is PCI for stable symptoms, for stable disease obsolete? For symptoms, the answer is no. PCI is definitely appropriate. But for stable disease, when you're talking about prognosis, at least as an initial strategy, it's mostly obsolete unless the patient has certain desires to get revascularized or go to the cath lab. Of course, keeping in mind that this excludes left main disease and probably excludes low EF, although revived BCIS sort of, shattered that myth. And again, we are interventional cardiologists. We may not like the data, but data is data. And I will just always emphasize that look at the data and don't fall for the other arguments which are smoke, because at the end of the day, what is hard data is the most important thing. Ladies and gentlemen, thank you very much, and I'm happy to answer any questions.
Thank you, Fahim. Very nice, powerful presentation as usual. We have an equally powerful speaker now for speaking against the motion, and it's Dr. Nadim Rizvi. It's over to you.
Thank you very much. I thought Fahim was speaking for con rather than pro. I'm just going to, he's a friend of mine, so I hope he wouldn't mind, but I was given the topic that is PCI obsolete for stable IHT. So can we have the slide? So can I have the next slide? So I think I don't smoke, and neither I'm going to have too much smoke. I will stick to let's not move the goalpost. The topic of debate is routine PCI obsolete for stable IHD? So what is routine? Next. A sequence of action that you do repeatedly, or a usual or fixed way of doing things, a customary or regular course of exercise. So let's just stick to the topic. So what is... So stable, we don't know, the definition's definitely not very clear, but patients with known or suspected IHD who have no acute recent change in their symptomatic status suggesting no active thrombotic process is underway. This is the most reasonable diagnosis. And what is obsolete? No longer used or out of date, not current or belonging to present type, replaced by something newer. So this is the debate. What do we mean? So let's stick to the debate. So let's look at the historical data, all-cause mortality, all these trials. These are historical trials. You can start from 1992 all the way down to our ischemia thing. No real difference. The curves are usually the same in all-cause mortality. In cardiovascular mortality, again, slightly shifted to the left, favoring PCI. These are the trials. I'm not going to go through it. I can discourage the Courage trial and defame the FAME trial, but we are not going to go into what Fahim has done. He has created a lot of smoke, and I'm just going to talk about data. All right, so non-fatal MI, no difference, but freedom for angina, look at the curves. So he's proven the point that all the trials show that the freedom from angina is better treated with PCI. So these are the bigger trials comparing optimum medical therapy and revascularization in chronic disease. The angina relief is definitely there, as you can see. All right, so what are the issues with trials of PCI versus OMT? The point estimate for all-cause mortality and cardiac death favored PCI in most of the trials, prominent trials, which had longer duration of follow-up. PCI was associated with greater freedom from angina in the overall analysis at all studied time points. Now, if all the statisticians go through these trials and, you can figure this. There was no standard definition of stable IHD. The heterogeneous inclusion criteria, for example, the Swiss 2 and the ALCEC trials, this is in French, in German. All participants had a recent MI and therefore may not reflect the same population of stable IHD as included in other trials. Older trials used balloon angioplasty only. The most recent trials in metastasis did not use the second DES, did not achieve current guidelines of low density lipoprotein. So we cannot, the ALK-Swiss trial I've already said, evaluated exclusively those patients who had MI within 1 month. So these are not stable patients. Severity of coronary artery disease based on number of vessels involved also varied. Courage and MASS2 notably included a high proportion of triple vessel disease, where usually surgical vascularization is a better option. And if you look at this Canadian propensity match trial, Canadians are pretty straightforward because there's no financial incentives. Look at all they analyzed 39,000, more than 39, stable IHD undergoing early revascularization or treated. They found over 4-year follow-up a significant reduction in death and MI with revascularization. There's a whole book by this Vijay Sundara. Just Google that and you will see Vijay Sundara and you look at it's a very well defined trial. Okay, so let's talk about the ischemia trial. The issues with ischemia trials is questions remain on whether the study design was the most definitive approach. The selected cohort does not represent the wider population of patients with chronic syndrome. The selection mode of revascularization based on normal clinical criteria had an inherent bias flaw and did not represent how we deal with stable IHD cases in the real world. A significant portion, about 35% had no angina on baseline. These are normal patients. This is not real life. There was an increased incidence of spontaneous MI in OMT group, which in all probability would have affected long-term outcomes in favor of revascularization. And angina relief and quality of life were statistically better with invasive strategy, durable out to 3 years follow-up, and this critical part of conclusion was not highlighted. So application of ischemia in the real world, patients with low symptom burden can choose OMT with an invasive strategy only required if there are ongoing symptoms, which we normally do. The study showed Also, the spontaneous MI in the conservative arm was higher, so this would have translated into a prognostic thing as well if we had followed up the trial. Considering the safety of revascular and significant improvement seen in quality of life with interventions, we can make an argument to offer an invasive strategy early in the patient journey. A key takeaway from ischemia study is that mortality in patients with chronic syndrome is relatively low with OMT, and treatment should be individualized to patients. This is what we do. This is a large near us. Indians are much closer to us. So this is Indian Heart Journal. Only 20% of patients have with stable angina. And studies in US have shown that 30 patients of stable IGD for every single patient of ACS. So there are about 900,000 PCIs being done in US. And for chronic stable angina, it's still 20% of the PCIs all over the world are done. So it's clearly not obsolete. Is relieving symptoms of any disease a bad thing and is now considered obsolete? Take hip replacement, angioplasty, knee replacement. Both are the... So do you do... 99% of procedures done worldwide are for symptom relief. Why are you talking about PCI for stable? You do procedures for symptom relief. 300,000 hip replacements a year, no prognostic difference. 965,000 angioplasties a year. This is US. 600,000 knee replacements a year. ACS, 772,000 per year. Stable high disease, still nearly 2 lakh patients are done a year. So relieving symptoms is not a bad thing. All right, so conclusion, historical and contemporary practice based on all evidence available in treatment of stable IHD has not significantly changed over the last 2 decades, whatever you say about the trials. You know, if the courage had come before fame and all that, we wouldn't be doing PCIs at all. So all this thing about doing it obsolete, I think it doesn't stand. So based on all the evidence, that is, in asymptomatic or mildly symptomatic patients, stable IHD, we treat conservatively with risk factor modification. That is what we've been doing for 20 years, and that's what we are still doing. So it has ischemia or revive or orbita has made no difference at all. In high-risk patients, we do MPS or CTA and then refer or defer for revascularization. This is what we do. Has ischemia changed that? No. In persistently symptomatic patients or GNMT, we offer revascularization, PCI or CABG, based on coronary anatomy or patient choice. So $100 million spent on ischemia, I think, was a total waste of time because it didn't give us anything new. $100 million on 10,000 patients. That's the cost of it. So this is all driven by a lot of the... Is routine PCI for stable IHD obsolete? No, it is not. That was the debate. Thank you very much.
Okay, thank you, Nadeem. Fahim, you there?
Yeah, I'm here.
So you have
Can you hear me over here?
Yeah, we can hear you, yes.
How are you all? So we are now in the cath lab number 2, and we have started off with another case.
Sorry,
the same new fresh
can you
team.
hold on the
Professor Cheng,
live
Professor Wajid,
case for
Dr. Zohaib, and Dr. Samra are over here with us, and they are coming up with another bifurcating case for you. I request Dr.
Bilal, can you hold on a minute?
To kindly explain the case for you.
Bilal, can you hold on a minute? We're just finishing the debate here, so we'll be with you shortly. Okay?
I think you can start the debate later on because now we are halfway through this case also.
Okay, we will be with you in a couple of minutes. Just hold on.
Okay.
Okay. So, Fahim, it's over to you.
Yeah, so I think Nadeem has made the points that I was making, that, you know, for symptomatic patients, it is not obsolete. I fully agree. It is not, you know, interventionists should not feel guilty for putting a stent to improve someone's symptoms. My point is that when up till now, all this time, and including, you know, people who trained, you know, in the last 15, 20 years, ischemia and treating ischemia for prognosis has been the emphasis. And I think that emphasis needs to go down. And it's driven by a sort of a new paradigm of understanding ischemia, in the sense that ischemia is not the prognostic issue, it is the atherosclerosis. And we have to focus on atherosclerosis and essentially try to work on atherosclerosis by lowering lipids, reducing risk factors, and those kind of things. Those are the things that improve prognosis rather than opening up the artery with a stent. So I think we're kind of saying the same thing in essence. that, that there is a role for PCI, but it is primarily for symptoms and stable disease, at least as an initial strategy. And secondly, none of this applies to acute coronary syndromes, which we see a lot.
Okay, thank you, Fahim. Thank you. Excellent point made. Nadim, you want to add anything here? You'll probably need to come up. So.
I think I accept whatever Fahim's saying in the good interest. We are both saying the same thing, but the topic of the debate was that PCI. So don't feel ashamed of doing, and I can tell you, I can assure you that in a few years' time, you will see that PCI with the newer equipment, newer technology, with the OMT will affect prognosis. There already, I can spend 1 hour here convincing you that prognosis is affected, except that it's in a small cohort. And these trials, statistical significance is not the same as clinical relevance. And this people don't understand. So that's why trials don't mean much unless you take the whole real view population. How can you compare, high volume centers, let's say for NICVD, how can you compare the volumes there and the expertise there with someone who's doing 11 cases? The guidelines of primary PCI were made on 125 hospitals on 200,000 patients all over the world. And just taking one single institution in Karachi, they're doing around 25,000 PCIs a year. Once they publish their data, you will find that it's totally, so 125 different operators in different countries. So I think I'll rest my case. I won't go into detail, but that's for another day. Thank you very much.